Biochemistry from Lovely Professional University.
In today's video, I will discuss a clinical case scenario of liver transplantation in which the patient experiences signs of organ rejection. My aim is to explain three main points. First, the immunological mechanisms behind organ graft rejection. Second, how immunosuppressive drugs help to prevent rejection. And third, the potential complications of long-term immunosuppression in case of liver. Let's start with the basics. What is transplantation? Transplantation refers to the surgical placement of a donor organ or tissue into a recipient to replace a failing or damaged organ. There are different types of transplantation. Autograft. Tissue transplanted from one part of the body to another in the same individual. Isograft. Transplant between genetically identical individuals, such as identical twins. Allograft. Transplant between genetically different individuals of the same species. Xenograft. Transplant between individuals of different species. Next, let's understand the graft rejection. So what is graft organ rejection? Graft rejection is the process by which the recipient's immune system attacks and damages the transplanted organ, treating it as a foreign entity. This damage can impair graft function or lead to graft failure. Rejection can be classified into three major types. Hyperacute rejection. This occurs within minutes to hours after transplantation. It is caused by preformed recipient antibodies, for example anti-donor HLA or ABO blood group antibodies, which rapidly bind the graft endothelium, activate complement and coagulation, causing thrombosis of graft vessels and immediate failure. Acute rejection. This typically occurs days to weeks, or even up to months, after transplantation. It may be cell-mediated, T-cell, and/or antibody-mediated. This is the type our case deals with. Chronic rejection. This develops over months to years. It involves more insidious injuries, vascular narrowing, fibrosis of the graft, low-grade immune injury, leading gradually to loss of graft function. It is important to differentiate these because the mechanisms, timing and management differ. In this case, the patient received a donor liver, but a few days or weeks after surgery, the liver started showing signs of rejection, such as elevated liver enzymes, jaundice, and poor liver function. This happens because the recipient's immune system identifies the donor liver as foreign and begins to attack it. The process begins when donor antigens, especially HLA, human leukocyte antigens, are recognized as non-self by the recipient's T lymphocytes. This recognition occurs through two main pathways. Direct pathway. Donor antigen presenting cells, APCs, from the transplanted liver present donor antigens directly to the recipient's T cells. Indirect pathway. The recipient's own APCs process donor antigens and then present them to T cells. Mechanism of acute rejection. In acute rejection, the key players are recipient T helper cells, CD4, and cytotoxic T cells, CD8. The process is as follows. Donor antigens, alloantigens, are recognized. Activation of recipient T helper, CD4, cells right-pointing arrow. They release cytokines, like IL-2, IFN-gamma, that promote proliferation and differentiation of cytotoxic T cells and B cells. CD8 T cells become cytotoxic, infiltrate the graft, cause apoptosis of graft. Donor cells injure endothelium, parenchyma. B cells also be activated, forming donor-specific antibodies, which contribute to antibody-mediated rejection, AMR, component. The result in the liver graft is inflammation, portal and lobular infiltration, damage to bile ducts and hepatic structures, impaired graft function, elevated liver enzymes, signs of graft distress. Immunosuppressive drugs to prevent liver transplant rejection. Now we move to how we prevent this. Immunosuppressive drugs are used in transplantation to prevent the recipient's immune system from mounting a rejection response. Some of the commonly used immunosuppressive agents in liver transplant include corticosteroids, for example prednisone. They broadly suppress immune activation and cytokine release. Calcineurin inhibitors, CNIs, such as tacrolimus, cyclosporin, they inhibit calcineurin, thereby preventing NFAT activation, IL-2 transcription, and T cell activation. Anti-metabolites such as mycophenolate mofetil, MMF, or azathioprine, they inhibit lymphocyte proliferation, e.g., MMF inhibits inosine monophosphate dehydrogenase, thus reducing T and B cell expansion. mTOR inhibitors such as sirolimus, everolimus, these inhibit the mammalian target of rapamycin pathway, reducing cell cycle progression of T cells. Induction antibodies, e.g., IL-2 receptor antagonists, anti-thymocyte globulin, may also be used at time of transplant to reduce early rejection risk. These drugs are often used in combination so that lower doses of each reduce side effects but still suppress the immune response enough to protect the graft. Next, let's understand what is the potential complications of long-term immunosuppression. It is important to be aware of the complications. Some of the complications include increased risk of infections, because the immune system is suppressed. Nephrotoxicity, especially with calcineurin inhibitors like tacrolimus or cyclosporin, reduced glomerular filtration, hypertension. Metabolic syndrome, hypertension, dyslipidemia, insulin resistance, new-onset diabetes mellitus. Cardiovascular complications, because of the above metabolic changes. Malignancy risk, de novo cancers, immunosuppression reduces immunosurveillance for cancer cells. Bone disease, osteoporosis, and other organ toxicity, hepatic, neurological, depending on drug. Specific drug toxicities. For example, tacrolimus can cause tremors, hypertension, renal dysfunction.